Welcome back to Fully Involved, the official podcast of Umatilla County Fire District 1. I'm Scott Stanton, your host, and today we're going to be diving into our community paramedic program. Today I'm joined with our community paramedic, Jess Markham. We're going to talk about where the program came from, where it's going, what it's doing today, and she's going to give us some great insight on who we help and how we help them. So welcome, Jess.
All right, thank you, Chief, for having me.
So, all right, first things first, what's a community paramedic?
That's a great question, and it's one not a lot of people understand. So we all know what a paramedic is and an EMT and a firefighter. But a community paramedic, also sometimes called a mobile integrated health provider, can range from a normal paramedic with an expanded scope. So yes, we can still run 911 calls and we help with those car wrecks and we do all those other life-saving things, but also we have an opportunity to really reach into people's lives in ways that we don't get to on a typical 911 call. In a typical 911 call, we have 20, 30, maybe 40 minutes, depending on the issue, to really help someone at their worst. But what if their worst is they don't have anyone to care for them, and that's why they're recalling repeatedly? And so, or maybe they have a chronic health condition that they don't understand and they don't know how to manage, and they can't get to a doctor's appointment, and they also don't qualify for home health, or they don't qualify for this service that could help them manage that at home. And so with community paramedicine or mobile integrated healthcare, the only difference with those being is that a community paramedic program has paramedics, and a mobile integrated health program could use EMT basics, intermediates, community health workers, that sort of thing. So if you hear the two terms, they're basically interchangeable. But we get the opportunity, especially with our program, to bridge those gaps. And that's what we talk about a lot, is we get to bridge the gaps of healthcare in ways that no other profession really has the opportunity to do, going from one crisis to another.
Yeah, I think that's a big thing that we've always recognized, is there was that gap. And obviously, let's go back a little bit, talk about the history. I know that for me, back when I maybe was a lieutenant or assistant chief, I can't remember exact time frame, with Chief Pat Hart, we talked about this program, and we finally got a chance to get it up and running with some grants, and you were at the right place, right time, right person.
Yes.
So can you take us back a little bit, talk about how we got the program started?
So this program for us started in 2017, and we went in for a grant with the hospital, with Good Shepherd Good Shepherd Medical Center. And so we got a grant for 6 months to see, we really want to focus on our high utilizers. And that was kind of the initial focus of the program, was our high utilizers. So we had to define what a high utilizer was. And that for us right now, and in most agencies, is utilizing 911 services more than 5 times in a year. And most people would go, oh my gosh, that's a lot. And for some of our high utilizers, they're on the 20, 30, and in some agencies as high as 70 times in a year for emergency services. And so you can see how that would be a big burden on emergency services to some degree. And maybe there's some better resources to utilize for that. So that's how we started. And we started with me as the full-time paramedic. We had a part-time person for a little bit, but with some funding, we had to cut that position back. And again, it started with those high utilizers, and as the program grew and the doctors got to know about it, the primary cares, and that sort of thing, we were able to expand our services to not just, hey, what can you do for this high 911 utilizer? Hey, what can you do for this patient that can't come into the office today? They're sick, they don't have transportation, they're homebound, they can't get here, but we're worried about them. Can you go check vital signs? Can you do a lab draw? Can you just listen to their lung sounds and kind of give us an idea of what this person needs? Do they need to come in? Do they need to go to urgent care? Or are they truly emergent? Because as we all know, our patients are great, and some of them are experiencing some difficulty. And the longer I do this job, the more I realize how complicated it is to navigate our healthcare system. So even some of those people don't understand, how can I manage this? And we are in no better position than anyone else to, or we are in a better position than anyone else to say, here's where we can get started, here's what's most appropriate, and here's how we can get there the fastest. So that's kind of how we started, if that's kind of what you're looking for.
Yeah, I can remember, I think the first 4 years, at some point, we got those grants from the Eastern Oregon Critical Care Organization, and they were awesome, and I know Good Shepherd was a big partner for us, and they helped with some funding even after those grant years went away for a couple years. So, it started, and we grew it with your getting in there in the trenches in a way and figuring out this stuff, because as a fire chief, I didn't know all of it. I knew it was a good program, but I knew we had to refine it, we had to grow it. So I think that's the great thing about it is, you've been here since it started. You've been able to grow it, revise it, reevaluate, do the stuff we need to set up for success. Hopefully not just for today, but for the future. We'll probably get into that, talk to you about what it looks like in the future. So let's talk about the people behind the numbers. Who does the program serve?
So that's a great question. We actually have the opportunity to serve many different people. So as we well know, there's a lot of situations that would cause someone to fall in the gaps of healthcare. And so we serve a kind of a range. So those who are high utilizers for the 911 system, the ER, a lot of our elderly is primarily what we see, usually associated with falls and that sort of thing. Chronic health conditions, maybe people have had major surgeries, abdominal surgeries, chronic health conditions like congestive heart failure, COPD.
So early on, one of the big pieces of this was referrals, like post, hip replacement or C-section, right?
Mm-hmm. Yeah, we started with that, and actually we don't see a whole lot of ortho patients, although some of our bigger finds have been in some of those. But we've kind of branched out to welfare checks from doctors' offices, lab draws for homebound patients, even some lab draws for pediatric patients who may have some conditions like autism that make it very difficult to get lab draws when they're older. So we've really branched out in a lot of different areas, and that's something I really love about the program is the flexibility with it, is we really get to serve people where they need it most.
And one of the big things that you've done for us to pass is when we have individuals that need some sort of care, you're able to fill that gap. And I'm thinking of one we're dealing with right now with an individual in town. We've had one, over in Stanton. I mean, can you talk about those specialty programs or specialty patients that you've had to really do a lot of extra work to help, be maybe an advocate for them as well? And
yeah, so for some of these patients and our providers, they don't know what the resources are or how to access them. And even people that not necessarily specialize in some of those areas, but some of these situations are so unique that people don't know, even sometimes within their own area, how to get long-term processes for people. So, and that's because they're complicated. Kind of like I alluded to before, is the longer I'm in this, the more I'm convinced that the U.S. healthcare system can be very complicated and difficult to navigate. So if you have someone that has just a little extra time to ask some why questions, what are the qualifications? How can we get you there? What's the criteria? Do you meet this? And where can we bridge that gap? That's all about bridging gaps in healthcare.
No, for sure. So a lot of people might be interested. What does a day in the life of a community paramedic look like?
And that's a hard one to answer because it is different every day. I have a couple things I try and do on a daily basis. We have our daily shift briefing. I have meetings for the hospital, so their roundings on what patients need, what their needs are for discharge. I also participate in some meetings on a bi-weekly basis with different organizations, and then that comes on top of my own home visits, lab draws, patient phone calls, care coordination. I'm also part of the Oregon Mobile Integrated, oh my goodness. I'm also part of the Oregon Mobile Integrated Healthcare Coalition as a board member there. So we're doing some work across the state to try and get this to be a normal service and to get it paid for through insurance. And there's also 911 calls. So being a paramedic with our agency and having some ability to care for patients with a monitor and IVs and all of that, we have a lot of calls. We have a very high call volume. And so being able to respond when our district needs it most is also something that I do, whether it's 5 calls out, because we have that often, or big MVAs.
I know that, speaking of that, I know there's times where you'll be able to jump and add to an MVA call, or you've realized, hey, that might be my patient. I think I recognize the address. You're able to get there, and that I know that helps our folks on the ambulance and troops that, hey, then they don't maybe need the ambulance, but they need something, and you're able to, again, fill that gap.
Yes.
So it probably keeps it a position where you have a lot of things you can poke around to. And
yeah, I love the flexibility, and also I love the relationship that I get to have with my patients. And I've been called different things over the years by patients. One of my favorite is when I first started this job is I saw this individual for a welfare check from his doctor, did EKGs, labs, physical exam, vital signs, all the things that he didn't have for years. And then that individual had to call 911 a few weeks later. And when I showed up, and he saw me, he goes, hey, that's my paramedic. And so that's what I love, is being able to have that relationship. And I've been called, that's my caregiver, that's my home health nurse. I've had a few different names that maybe aren't the most accurate, but people do know I'm there to care for them. And that's what this program has the capacity to do.
Well, and I think we mentioned earlier that I think there's some data that people heal better in their homes, right? So you're being able to go into their homes, and they're probably more comfortable. Maybe they have issues with getting to a doctor or to a clinic or something. Talk about being in folks' homes and that relationship of building with them and stuff like that.
Yeah, so when someone has a crisis in their life and they have to call 911, and the paramedics do a great job, they come in, they swoop in EMTs, and they get that person to the hospital, and then the hospital does a great job by getting them stabilized, getting them healthy again. But in all of that, when you see a few people on the ambulance, then you get to the hospital, and then you go to the ER and you see doctors, nurses, physical therapists, registration, lab. You get upstairs, you see more doctors, nurses, physical therapists, lab, occupational therapy, all these other people. And then you get home and they give you a stack of paperwork and say, hey, here's some really important information, here's where all your follow-up appointments are. And they do a great job trying to explain that, but that person's overwhelmed. They get home and the first thing they do with this paper typically is, that's going to go on this counter, it's going to go in the garbage, it's in a bag for over here. And so once they have a chance to rest, and that could be, a couple hours to a few days, they don't look at any of that. And so if there's really important follow-ups that need to happen, or there's medication changes, that's why we try and get into someone's home within 48 to 72 hours of the discharge, is so that we can catch those things and catch them early.
So when you get into the home of somebody you're going to visit, can you talk about, I know you probably do a million things, or you can do, depending on what you're presented with or what the needs are of the patient, but give us a little overview of the highlighted stuff that you do, whether it's an EKG or patient history. Can you fill us in a little bit on what that looks like?
So depending on the reason for the visit, but for example, let's say our high 911 utilizers. I'm a pretty big believer that people call for a reason, and sometimes it takes a little detective work to figure out what that reason is. And so, because sometimes they don't even know. So some of the things that we do typically, or I do, is we do a social needs assessment. So we look through what resources do you have and what do you need. So do you have a primary care? Do you have any specialty doctors? Do you have caregivers? Are you connected to the state for services? Do you need connected to some of those services? Are you a veteran? Because veterans have services that many others don't, and there's a service percentage to what you can qualify for. Do you have smoke detectors? Do you have carbon monoxide detectors? Are they working? Are they tested? We check vital signs. We check what pieces of medical equipment you have. So do you have a walker? Do you have a bath chair? Do you have any of those things that you need? And if not, what do you need so we can make you successful in the home? We check physical exams. So if you went in, for example, for a surgery and you have a surgery scar, or not scar yet, but a wound, we can check that to check for signs of infection. So I did a 6-week wound course with University of Washington when I kind of earlier on in the program, so we can identify potential signs of infection. What do you have dressing wise to cover that? We check for smoke detectors, like I said, those types of things. Fall risk assessments. Do you have clutter in the home? Do you have not enough medical equipment? Is there loose rugs, not good lighting? We can start to identify what some of those things are.
And you can even do some advanced stuff like labs, or obviously 12-lead ECGs, stuff like that.
Yeah. So we still have all of those same skills that a paramedic has, just it's enhanced, right? So I can still do those physical exams. Based on those physical exams, we can figure out, do we need to do a 12-lead EKG? Do we need to draw labs to see where your levels are at? Because in the hospital, they were way up here, and maybe now you're way down here, or maybe you're rising back up again. We have the ability to do urinalysis tests. One of our number one things for falls and confusion with elderly people is urinary tract infections. So we can check for those. We did have an A1C machine that we can use as well. I don't use it very often because it's sometimes easier to go to the lab and get a tube, and it's cheaper. But we have some abilities to do some extra testing that can start to pinpoint what the biggest issue with that person is and how we can help them.
I get the feeling you might be doing some education with these folks too.
A little bit, and that's probably the majority of what we're doing, is not so much we don't do any sort of diagnosis. So that's really important to know, is we've gotten phone calls in the past of, hey, I think you need to go talk to them. I think they have this going on. Well, we can't do that. We just enforce what your doctor or the doctors at the hospital have already told you for the most part. So that nice, beautiful packet of paperwork that they gave you after every doctor's visit and a hospital discharge, and you took home and went, that's a lot of stuff. It's been overwhelming. that's going to go over here for a while. We just talk about that. So we give them, hey, did you understand it? Did you read it? Let's talk about a few things to watch out for. Here's when you'd call 911. Here's where we should call your doctor, and start to make sure that that is clear, because many people don't understand that.
And it seems like today's world, when you go see the doctor, it's pretty fast. And with you, it seems like, and maybe you can talk to that, how long you spend at a visit, but you have the time to spend some quality time to really dig in there, where maybe a doctor doesn't have that much time to do that.
Oh, absolutely. Yeah. So I can spend anywhere between 30 minutes and 2.5 hours with a patient. It just depends on what they got going on. Some of those are pretty simple. Some of them can be very complicated, especially when you throw in 2 to 3 pages of medications. And how do you organize those? Do you know what your medications are for? Okay, maybe you had a change here in this medication. You're only supposed to take half, and you're taking a full dose, and maybe it's of a blood pressure medication, for example, which is why your blood pressure is pretty low today. So maybe let's give your doctor a call and make sure we're doing the things that we need to be successful.
So to kind of finish this little piece of that, of a typical visit per se, how do you interact with their primary care physician, or if you find something, who do you go to? Who do you contact? How does that work, that relationship with maybe their doctor?
Yeah, so it depends on, again, what I'm seeing them for. But there's been emergencies or calls that I show up and turn into an emergency call, and that kind of escalates from there. But if I find something that I kind of laugh a little bit of, that's not actual 911, but still kind of there with 911, that's what I get called for a lot is, we don't want to call 911 yet, but can you kind of like be that little intermediary between, is it really emergency or is it not? So with that, if I find, for example, someone has a medication error, or one patient that I had at one point had a routine, I think it was a knee replacement or knee surgery of some sort, and taking their blood pressure, I could hear that their heart rate was very irregular. And I asked that person, do you normally have an irregular heart rate? And they said, no. I went, okay, well, that was a phone call to the doctor. We did an EKG. That person was in a new, what we call AFib, or atrial fibrillation, which, especially after a surgery, has a potential to throw blood clots. And those clots can go a few places, for heart attack, lungs for pulmonary embolism, or the head with a stroke. And so that was something big we could catch. And we coordinated with that doctor. They wanted them to go to the ER in that instance. But we found new heart rhythms, we found potentials for infections, and so that opens up some doors to catch things early. And one, if you catch things early, right, you don't have to spend as long in the hospital. You may not even have to have a hospital stay, and it's cheaper for everyone and a lot less hassle.
So we've talked a little bit about partnerships already, so how about we talk about Good Shepherd Medical Center, the foundation, on those folks you work with. I know it's a lot bigger and wider than that, but can you expound upon how have you grown our partnerships through the fire district with everybody?
So we started our program on a grant through the what's called the EOCCO, or Eastern Oregon Coordinated Care Organization. So the short version for that, it's our area Medicaid. Medicaid is broken up almost by county or certain regions throughout the state. That one's ours. And so we have a partnership with them. So we have some access to some additional care coordination meetings, some complex care management teams that we can send some of these patient referrals to. I do a lot with the hospital, so I'm pretty involved with their case management team, occasionally at the ER, but I try very hard to keep people out of the ER, so I'm not there as often. I work with their primary cares, lab, home health, hospice, a lot of those areas, and it's expanded quite a bit outside of the hospital and insurance companies as well. So I work very closely with Community Counseling Solutions. I'm working with COPES a little bit more, who works with our substance abuse, and so that's a big area of high utilization for 911 and ED visits and repeat hospitalizations as substance abuse and mental health. I work with the Agape House a little bit. Again, I've mentioned Clearview, Medical Loan Closet in Pendleton. And there's kind of new partnerships all the time. So we have other fire districts that are close to us that, especially if it's, for example, Umatilla, that they go on lift assist, but they don't call us to transport. Maybe they have more information on this referral that they sent me that they can provide. And there's new ones all the time. So I've worked with Stepping Stones on a few cases as well. It's my network has grown pretty significantly, and I'm very grateful that we have very good community partners that care a lot about our people here, and we are really able to bridge those gaps in care together.
So what kind of impacts have you seen since we started the program, say 8 years ago?
Oh, that's a great question. I think a lot of it is people have a place to go, is the shortest version I could put it. Is not only do our firefighters, paramedics, and EMTs have a place to go, hey, we saw this person, we know we're going to see him again, but there's nothing we can do as 911 providers for him. They have a place to send that person. That person who bounces between, it's not fully emergent, but it's also not normal, but I don't know where to go. It's, I had one this week where it was a prior patient of mine, had a caregiver, that caregiver had a medical emergency, wasn't able to care for the person anymore, and their family members contacted me saying, we don't know what resources are there, we don't know what to do for our family member, can you go out and just make sure everything's okay? And so it's getting people to I think we've talked about before, the right care at the right place at the right time. Mm-hmm. It's all of that, because with our program, we have the opportunity to bridge gaps with a lot of different places and people. We don't have any restrictions on insurance. We don't have restrictions on necessarily where you live outside of, our typical Umatilla, Morrow County areas, but we don't have the restrictions that a lot of people do. And so that makes us flexible to really meet those needs for people.
I know we've had this talk before about the expansion needs, or the needs of the program, and how do we expand it and make it better. Talk a little bit about, to our folks out there, where do you see the program going? I know a lot of it comes back to funding, and I would love to hire another person right off the bat, but no funding for it. So talk a little bit about where maybe you see in the next 2 to 3 years, where do you think the program would like to be if we had the funding to support that? What do you see?
If we had the funding, which is always a big factor, but I am on the board for the Oregon Mobile Integrated Healthcare Coalition. And so what we've been working to accomplish through some of that work is to get this as a light item for insurance to pay for. Mm-hmm. So we could actually treat in place, and that would be a huge part of it. That's how other states are kind of funded. But if we had the opportunity, I think we could make this more of instead of my Monday through Friday, 8 to 5-ish kind of deal, we could really start to meet those people at, for one of my high utilizers for 911, they like to call between 2 and 4 a.m. And, when you try and call them at a, normal daytime hour, they're not answering the phone and they're not going to return your call. So we can start to get to see some of those people that we don't have the opportunity to, and really start to bridge those gaps there, because people who are already resistant to change and resistant to care aren't excited about a stranger calling them. But if they called you there already and you show up to help them, they're going to go, oh, you actually are going to help me with this? Okay, well now I have some trust there. Yeah. We can actually start to bridge those gaps.
So there might be people out there that think, hey, that's a cool profession, maybe I want to be a community paramedic. Can you walk us through, what does that look like for someone who wants to be a community paramedic, and how did you get there, I guess? What extra classes have you sought out and found?
So when I started this job, and there's not a specific standard for Oregon yet, but the standard is going to, we're trying to get to, you get a community paramedic certification through what we call the IBSC, or the International Board of Specialty Certifications. If I'm honest though, it really depends on your community. So when I started this job, I just had my paramedic certification, and it was through conversations with doctors, primarily doctors, of what they would say, hey, I saw that you sent me this letter, because that's what I do after all my visits, is I send a letter to their primary care saying, hey, I saw your patient, here's what's going on with them, and here's kind of what the recommendations are. They need an order for home health, they need a wheelchair, something like that if it has to go through insurance, they can make it happen, because they're kind of the gatekeepers for that. But they started asking questions of, hey, before you see my patient, I want to know, do you know what wounds look like? Can you describe them to me in a way that I can picture it, and can you take pictures of it, and maybe do you understand what this extra education is on this specific health condition, diabetes, COPD, stuff like that. So I did obtain my community paramedic certification last year, and I also did a 6-week wound course with, like I said, the University of Washington, so I can identify them, describe them, have an idea of how to treat them, and sometimes if some of the other agencies either leave supplies in the home, I can kind of help bridge those gaps again. That's kind of what we do. I've done some mental health training with CCS, a little bit of their QPR, motivational interviewing, ACEs, so it's kind of more of what do your local providers really want to see you do and get interested in. So, but the main one is probably that community paramedic certification.
a lot to it.
Yes.
Not just the medical part, but the educational part, the social worker part, the community health worker part. It's all rolled into one for you, at least here.
Yes.
So that's great. That's awesome. So another thing we're talking about, getting people to want to be in this profession. Any advice you can give to young people if they want to become a paramedic, or if they're a paramedic but want to get into this? What advice would you give to them?
It's a very exciting career, and it's one that can be very fulfilling. It's also one of the hardest. As a paramedic, you know kind of what you're getting into. You're going to go deal with this trauma, this medical event, and it's going to be over. As a community paramedic, you're going to be spending some time there. So I didn't know much about hoarding when I got into this position, and now I realize there's a scale from 1 to 5, and I can describe those layers very, very easily, but also just getting to be an expert in your community resources. So if you're someone who enjoys helping people, likes problem solving, and you like building community or partnerships within your community and your patients, it's a people-oriented career to some degree. So it's very rewarding, and I enjoy it, but it can be, you're ever learning in this job.
Good. So we know that not every community in Oregon has a computer paramedic. Can you talk about what makes us unique to have the program, how that compares to the rest of the state? And then let's talk about maybe an award you maybe recently got.
Yeah, not everyone has a community paramedic, or in other areas of our state it's called mobile integrated health, but not everyone has those. And so the agencies and departments that are willing to invest in those, I think, see a lot of improved healthcare and whatnot from theirs. But it's not easy to do, and it really depends on the needs of your community.
We have the fire district here, but how far and wide have you gone, or do you go to see, say, patients at? Where do you go to see the patients?
So technically, with our contract with the Eastern Oregon Coordinated Care Organization, or EOCCO, we go throughout Umatilla and Morrow County. So I can go to Milton Freewater. The majority of what I do, probably 80%, is in Hermiston. A little bit of Umatilla, sometimes Stanfield, Echo. And on the more rare occasion, I'll go over to Umatilla or Morrow County.
But you've been to like Heppner and Pilot Rock before, like little towns on the south end of the county. So even.
Yeah. So I do go to those places on occasion, and again, there's very little resources. People don't know what to do, how to coordinate care for those individuals.
So I know you've spoken at several conferences the last few years all over, but you just got a pretty good award for a national award. Can you speak a little bit about that?
So our program did receive an award through the National Association of Mobile Integrated Healthcare Providers. It's very wordy. They call it NOMHP. But they wanted to pick out programs across the nation that are maybe doing some unique things. So I think we got one for social determinants of health. So meaning that we found some social reasons why people might re-encounter the emergency room or 911 services. And so they were able to pick one of our examples of our patient success story, and we used it for that.
And you got to go to Indianapolis, wasn't it?
Yes, the EMS World, they had a MIH summit, and so I got to experience that in Indianapolis, and that was very, very exciting. I've never been there.
That's cool. So kind of a sidebar question. You've got a family, husband's in law enforcement. Talk about work-life balance for you. What does that look like for you? Because I know you do some stuff. You coordinate our peer support group team here. Tell me about how you do work-life balance, because I know you're doing other stuff here, like peer support and stuff.
Yeah, I do have a little plaque on my desk that says Chaos Coordinator, because I feel like that's what I do, whether I'm at home or work or anywhere. But my biggest work-life balance is intentionality. So when I'm with the person that I'm with, whether that's a patient or a peer or at home, I'm intentional about my time with that person and giving that my full attention at the time. So good. I'm not saying I'm perfect at it, but I do my best to do that.
The takeaway is be present with who you have in front of you.
Yes.
Awesome. I know, because that's busy. 2 kids, husband, and although you do work, is I know that sometimes you fill in on the ambulance at times. You just kind of fill in. I know you do lots of peer support stuff. You are part of the big reboot. You're part of the reboot program we have here that you do, and it's just a lot of stuff. And I just can't believe, I'm so thankful for all the stuff you do. You do an amazing job of all that. And what is your highlight? What's the number 1 or 2 things you just love about this job?
I think if I can go back to a story that I had for one of my first set of patients, they were high fall risks and used 911 a lot. The short version is we were able to get that family closer to their family. They went to an assisted living facility for probably a couple months and then moved out of state with their family. But prior to them moving, they invited me to their going away party. And I thought that was pretty unique. I'd only worked with them a couple times, but it meant that much that I got an invite there. So just getting that personal relationship with our patients, I think, is so unique and not something that we typically get to see with EMS. And EMS, we typically see people on their worst days, and we don't always get to see them on their best.
Yeah, it's usually pretty fast when you're there in the ambulance or something and take them hospital and gun, so that's awesome. So not only are you filling the gap in our community, you do some pretty special stuff here internally with our own responders, like the Reboot program, and I believe you're our peer support team coordinator. Can you talk about that stuff? Because that's hugely important, that behavioral health that we always are working on in the fire service and the EMS world. So,
yeah, so we've had the opportunity to start our peer support program, and I'm very grateful for that. We have typically, when you look at first responders and the numbers of PTSD, depression, anxiety, substance abuse, they're much higher than the normal public. And we talk often in peer support of the average first responder will experience about 188 critical incidents within a 20-year career. So we define a critical incident as a fatality, for example, like a big fatal car wreck, for example. Sometimes suicides can cause some issues for people. Going on a pediatric call, going on a call with someone you know, and being in a small community, man, how much do we have that opportunity to do all of those things? So the average person will deal with, I think the official numbers are like 1.5 to 2 of those. So when you put that in comparison of how much first responders deal with compared to the average public, and it's significantly higher. And so with those significantly higher numbers of critical incidents, we have a higher rates of some of those mental health conditions. And so having the opportunity to provide an outlet for those people that give all they have to this community has been great. So we have a peer counselor, so I'm also a peer counselor, that's what we call it. So we give them a place to talk and get resources. So we have some devices that our agency has purchased. Alpha Stim is one of them, and it helps our brain get out of that hypervigilant mode, that fight, flight, freeze type of brain before we go home, so we can actually go home relaxed with our families to some degree. We have some contracts for counseling and some other resources that have been very helpful.
So on the Alpha Stim, is it being used quite a bit?
A lot by our first responders.
And so normally when they come off shift in the morning, they would put it on then?
Yeah, it's great for a lot of things. I think the thing that our crews use it most for is sleep.
Yeah.
So when you're woken up, I think our average call volume is 17 calls in a 24-hour period, and even if that's across 3 stations, that's still a lot of getting constantly woken up, and that will disrupt your sleep schedule quite a bit. So
we talk about sleep. One of the things with our bond and the remodels of all the stations, we've actually for the first time added our station alerting systems in, which will have hopefully some ability for folks to choose the ambulance or engine and not get woke up as much, right?
Yeah.
So unit level dispatching, all that comes into play. But can you speak a little bit about sleep deprivation on first responders and how that Alpha Stim we really to try to bot for some of those reasons?
Yeah, so sleep deprivation is a huge issue that we have kind of currently, and that's just a little bit of the nature of the job right now. So we're putting things in place to help with that, but also when your brain has been trained for years of you hear that tone go off, you're up, you hear people walking around, you're up, you hear anything, sometimes any little noise, you're awake and you have a hard time going back to sleep. But what this Alpha Stim does is it sends, and I'm going to not give it all the justice it's due, but it basically sends some signals almost like a TENS unit, but better, to the back of your brain, and it really relaxes that part of your brain that puts you in that fight, flight, freeze response. So if we can do that before we try and go to sleep, before we go home, we have that chance to actually get rested on our days off to come back and be that 100% that we need for our community.
Kind of decompress a little bit.
A little bit.
Good. So as we're wrapping up here, I want to talk about how do people, if they need something, or how do they get a hold of you? How do they know if they need your services? Talk a little bit about how do they access if they think they need your services?
So a phone call is always the best start if you need it, or if you feel like you have a family member that needs it. My biggest request is we don't do self-referrals at this point, and we've tried to make this very clear, is we're not a replacement for any service. So we're not a replacement for a doctor's office or anything else, any other service, home health, any of those. So we want to make sure that we're getting you the appropriate resources for the time. So I would encourage you to call your doctor, or to, if it's a family member, calling their doctor and saying, hey, here's what our need is. Can you send a referral? And then that way I know with the best, most accurate information what's going on with this person and how we can bridge those gaps. The other part that I kind of say often too is I might not have all the answers, but I usually know where to find them. So if you don't know what your needs are, and that's a lot of people, is I don't know exactly what I need, but I know I need something, we have an opportunity to talk that through. So you're more than welcome to call my office, and we can kind of troubleshoot to what might be the right resources for them.
And we need to let people know this is a free program, right?
Correct.
They're not going to get a bill. You're not going to ask for a credit card.
No.
So
that's part of my favorite part of this program so far, is we've been very blessed to be able to do that with our partnerships. I know our fire department kind of puts forth the majority of that budget for this program, but we can take down a lot of barriers with that, of just being able to connect. Even if I don't do a lot for people, there's a lot of patients or people that call and say, hey, I got this going on. I go, okay, well, you know what, this is actually a really good resource for you over here, and we can actually start to just point people in the right direction.
Yeah, for sure. Is there anything on our website that can help people that might be interested to know more about the program?
Yeah, so we just changed our website from, and it's now www.ucfd1oregon.gov, and on that is a community paramedic tab. If you click on that, it has information about the program, and as well as my contact information there.
Well, Jess, it's been a great overview of the program day. Thank you so much for being on the podcast.
Thank you for having me.
So if you're listening today and you want more information about our community parenting program and Jessica Markham, you can go to our website, and don't forget to like and subscribe. And I appreciate everybody coming by, checking us out here on our podcast called Fully Involved. And we hope to see you very soon. Thanks for checking in. If you have any questions or topics that you'd like us to cover in future episodes, please let us know. Until then, stay safe, stay informed, stay involved. Thanks for being here.